It's my distinct pleasure to welcome today Dr. Allison Tong from the University of Sydney, where she serves as a senior research fellow. Dr. Tong has done tremendous work in the area of kidney medicine research, and especially research that involves patient preference information and patient-reported outcome data. She's an advocate for having patients drive kidney research and kidney medicine, and she's here today to talk about some recent research that she has done on the role of language and nomenclature in working with kidney patients and working with researchers. She recently published a paper in the Clinical Journal of the American Society of Nephrology that takes a look at how language can become a barrier to patients and patient engagement in their own disease and also in research studies. It's my honor and a distinct pleasure to have Dr. Tong speak with us today. Dr. Tong, go right ahead.
Hi everyone, my name is Allison Tong. I'm from the University of Sydney, and I'd just like to thank the American Association of Kidney Patients for the opportunity to give this presentation on breaking the code, kidney disease in plain language. And I'd also like to specifically thank Paul Conway and Richard Knight for this opportunity. I thought I would begin with a quote from a patient who said, "The connotation of end-stage or end-stage kidney disease isn't helpful. Your kidneys fail and so will you. So by association, your physical existence is failing. Kidneys are reducing function might be better, and we need to separate it from the person." So with the current kidney terminology, is it patient-centered? So it's been recognized that some of the terms that are being used to describe kidney health are inconsistent, difficult to understand or inaccessible, and may be conceptualized differently between patients and clinicians and researchers. And this can really impair the communication and also the quality of care for patients with kidney disease. Some of the terms may even be regarded as degrading, demoralizing, and disempowering for patients. And this can consequently lead to reduced satisfaction, adherence, autonomy, and also capacity for making decisions and self-management. And just a little bit of terminology trivia, I suppose. So the word kidney was thought to come from the early 14th century and was derived from an Old English language. The word renal from the 1650s came from the French renal, directly from the Latin translation. And nephro was actually from the Greek term nephros, or kidney. So in recognition of the problems with the terms currently used for kidney health, KDIGO, or the Kidney Disease Improving Global Outcomes Initiative, set up a conference, and this conference included all the editors of medical journals in the area of kidney disease. It also brought together patients to standardize and refine kidney-related nomenclature through a precise in developing a patient-centered glossary that aligns communication in clinical practice, but also in research and public health. So really trying to make terms more patient-centered. And just on the left slide here, there was a presentation by one of the editors from the Journal of the American Medical Association, and bringing in focus the need to use patient-centered or patient-first language. And as part of this initiative, we conducted focus groups with patients and caregivers or family members. So we included patients with chronic kidney disease, all stages, including patients who do not yet require kidney replacement therapy, patients receiving dialysis, and also kidney transplant recipients. And we also invited family members to these groups. In total, we conducted 10 focus groups across 6 cities, including Dallas, Houston in the United States, London and Sheffield in the UK, and Armidale and Sydney in Australia. We used what's called purposive sampling because we wanted to try and achieve a very diverse range based on demographic characteristics and also clinical characteristics. And we invited patients from the KDIGO patient network and also the hospitals involved until we reached a point of saturation. So we conducted focus groups until when little or no new concepts or perspectives were being identified. So as part of these discussion groups, we did focus on a number of key terms or words that were used. So this included kidney or renal, chronic kidney disease, pre-kidney replacement therapy, the term end-stage kidney disease, kidney failure, words related to kidney function. So this included things like the glomerular filtration rate, and we also had some discussion around the stages of chronic kidney disease. And the questions posed included, what terms were difficult or challenging for you? Why were these difficult? What did these terms mean? What impacts did they have on you? And then how would you describe the severity of kidney failure? So with these focus groups, we recorded and transcribed all the discussions, and we analysed the data using thematic analysis to try and identify themes that reflected the patient's perspectives. We used investigator triangulation, so we had a couple of researchers involved in the analysis, and we also used member checking, so the results were sent back to all the participants to ensure that we captured the full range and depth of the data that were collected. So in total, we had 67 participants in these groups, and this included 54 patients and 13 family members or caregivers. 24 were male, 43 were female. We had 21 from the US, 28 from Australia, and 18 from the UK. We had kind of different ethnicity groups included and a range of ages. And an interesting one to look at may be the education. So we did have patients who'd finished up to 10th grade, 12th grade, and also patients who'd completed a professional certificate, an undergraduate degree, and postgraduate degree. So before launching into the themes, another quote from a patient who said, it's about making things simple for everybody so that language isn't a weapon. And I thought this was quite a powerful quote to include here. So we identified 4 themes to summarize all the discussion. This included words provoking and exacerbating undue trauma in patients, being frustrated by the ambiguity of terms used, trying to make sense of the patient's prognosis, and on the other hand, words that help to mobilize or to support self-management. And I'm going to go through these in a little bit more detail with some quotations from patients to highlight these as well. So the first one, provoking and exacerbating undue trauma. This related to patients kind of fearing the unknown and some words denoting impending death. Patients also talked about despair in having incurable and untreatable disease. They thought some terms were prematurely labeling them and making assumptions about them, including their treatment, and also instigating judgment, stigma, and that failure of self. So some of the terms used can cause potential harm. So on the left here are some quotations. So for end-stage kidney disease, one patient said, it feels like you're on a cliff and you're about to fall off. It was quite traumatic and scary. Chronic kidney disease, this sounds very terminal and final, and it feels like there's nothing you can do about it. Another patient said, I would rather you educate me as to what stage I'm at than using a term or word that doesn't apply to me, such as pre-dialysis. Dialysis doesn't apply to me right now, so why do I need to even use the word? The connotation of end stage isn't helpful. Your kidneys fail, and so will you. So by association, your physical existence is failing. We need to separate it from the person. When you get diabetes, they don't say you're an end-stage pancreas failure. They say you've got diabetes, you're going to have to use insulin. It's a completely different thing. It's not this, oh my gosh, my pancreas isn't working. So this next theme was around frustration with the ambiguity of some of the terms. So patients and caregivers talked about being confused by language that was highly medicalized, lots of jargon being used, lacking personal relevance to them, being baffled by the lack of precision in the meaning of the terms used, and being opposed to terms that they thought were obsolete. So with some of the quotations, I used to get confused about kidney failure, and my nephrologist would say, well, you're not in kidney failure yet, you've got kidney disease. He was using it as the endpoint kidney failure, but I was thinking my kidneys are failing. When they put GFR there for you to read and understand that they have in parenthesis that if you're African American, it's a different number. but they didn't explain why it's a different number. I never thought of myself as having end-stage renal failure because I was on renal replacement therapy. And the last quote, the more technology develops, the less appropriate the word end becomes. For the majority of people, there are life-sustaining treatments, dialysis and transplant. So this theme was about patients saying some of the terms cause more uncertainty, particularly around their prognosis of their health. This related to wanting to conceptualize their level of kidney function, correlating with symptoms and life impact, and being able to predict progression and the need for interventions such as dialysis or transplant. So the percentage, this is where I'm confused. If it has to be over an eGFR glomerular filtration rate of 60, do you consider 60 100%? I mean, what percentage is the 100% because it could be up to 115? By sticking with meaningless terms like stage 1, stage 2, I had no idea what the symptoms of early stage were or what they need to be. They need to be educating you on what's going to happen or what could possibly happen to your body and what you'll be going through. I was in stage 5 chronic kidney disease and I still didn't have any symptoms. And with reference to the staging of kidney disease, another patient said, it's good in terms of qualifying where you're at in that. Is it one of those things that you put a time on to it though? Because that's the difficulty. So the final one was about supporting or mobilizing self-management in patients. So for some patients I said, well, these terms, it forces them to confront the reality of the situation, of what's happening to them. It could also enable planning and preparation, to take ownership for change. It's also an opportunity for them to learn medical terms for self-advocacy. It's about educating others. So a patient said, the words are kind of damaging and painful to the patient, but they're a necessary damage. End stage is a really harsh term, but it's a good term because you have to drill at home that it's really the last stage of whatever you're going through. If you'd been told that you're a stage 5, I would have been like, oh, it's just stage 5. I can still reverse it. It's beneficial in that they give you a sense of planning and to make decisions about dialysis or transplant. If you're saying pre-dialysis in my mind, that says I'm about to go on dialysis, but then I'm going to wonder, is there something I can do to keep me from going on dialysis if you put it that way? And finally, understanding the big words. Although it can be intimidating, this is your life. So after the focus groups and the conferences, we were tweeting out some thoughts, and these were some of the reactions from the kidney community, including clinicians and patients. And just by way of example, some patients said, they agreed, with chronic, many people think that it means terminal and it takes away that hope. Another said, yeah, end stage does sound like death is imminent, whereas kidney failure now needing treatment as a general description. And as an individual conversation, stage 5 could help the discussion of what this actually means to the patient. Another one said, I have never actually thought about this before, but end stage does sound somewhat dramatic. I think stage 5 works well and would also support pre-dialysis to differentiate those who are imminently choosing or starting their kidney replacement therapy. So this did generate a lot of debate, discussion, and thinking around the terms used for kidney health. Thought I'd also bring up whether this is an issue of health literacy. So the Institute of Medicine defines this as the degree to which people have the capacity to obtain, process, understand basic health information and services needed to make appropriate health decisions. And this is quite a big topic now. This is also about communication in research, practice, and policy. It helps to promote understanding and engagement in care in chronic kidney disease. There's been studies that have actually found with limited health literacy, it increases the risk of hospitalization, reduced access to care, and worse quality of life. So it is an important issue. And in terms of the role of the words and vocabulary used, it can be incomprehensible, imprecise, and it may even cause catastrophizing. So it has implications for health literacy. So here, patient-centered terminology may actually offer an opportunity to improve health literacy in patients. And just an example from another discipline in tuberculosis. And there was also an article here questioning, can we change to patient-centered terminology and stop the paradigm of blaming patients? This is just a couple of examples. Typically, the terms that had been used to describe patients with TB included words like defaulter. And this can have very negative connotations because this relates to a person who's failed to fulfill a duty or obligation, for example, failing to repay a loan or failing to show up in court. So they've now proposed a new term to avoid this sort of blame game and called them a person who's been lost to follow-up. There were also previous terms used to describe patients such as, suspect or control, which they've now replaced to more neutral, perhaps more acceptable terminology, person with presumptive tuberculosis, person to be evaluated for tuberculosis. So I thought this was an interesting example of how words can actually blame patients and the need to change this. So drawing from those focus groups, there are a number of suggestions that came up. So to avoid the term end-stage kidney disease, to try and minimize that undue confusion, the trauma and the distress. To use the term kidney instead of renal because this is more understandable. To avoid terms such as pre-dialysis because it can be quite confronting. The use of terms to describe the level of kidney function, so glomerular filtration rate, low clearance, and so on. These may need to be supported by education, which includes discussion around symptoms and also the need for treatment or interventions. Kidney failure may be an acceptable term, but this really needs to be supported with counselling and to really clarify that this is referring to the kidney, not to the person, and that treatment options are available. And to provide information in a comprehensible, compassionate manner that takes into account the patient's individual context, their circumstances, their preferences, and also their concerns. And this work has now been published in the Clinical Journal of the American Society of Nephrology. And with this publication, it was actually supported by an editorial by Paul Conway, and I thought I'd just share an excerpt here where he wrote, "Professionals must place greater thought in how they communicate with patients, the specific language they use. If our shared agenda is to have more patients participate in clinical trials and research, take better care of themselves, and become more involved in advancing policies that support innovation and research, ask yourself a simple question. Did the last conversation I had with a patient inspire confidence that his or her kidney disease is manageable and that his or her unique patient insights are valuable and needed in the fight to help save other patients?" And I have to say, I really couldn't agree more with this. So the work that's being done will actually be implemented in one of the editions in the American Medical Association's Manual of Style, the Glossary recommended for use. So just by way of example, so the KDIGO recommended in terms of kidney function and disease, they suggested the term kidney should be used preferentially when describing kidney disease and kidney function with some exceptions, and that terms such as renal could be avoided. Another example, so for kidney failure, used to describe when the glomerular filtration rate is less than 15 or when treatment is required by, say, dialysis. And terms to avoid would be terms such as end-stage renal disease or end-stage kidney disease. So just to summarize, words really do have power. And they do have power to empower patients with the knowledge and ability to make decisions and also for self-management for better outcomes. So the use of patient-centered terminology for kidney health really does have potential to improve patient autonomy, satisfaction, and also outcomes that are important to them. And I'd like to close by just thanking all the patients and family members who were involved in this project and for their very valuable contribution. Thank you so much.
Thank you very much, Dr. Tong, for your presentation. And now a quick question for you. You work with so many young researchers around the world, and the importance of your recent publication, your paper on language and nomenclature. I just have a simple question, really, which is this. Do you think that working with younger doctors, they understand the need for clear language with patients? And do you think that these younger doctors, by doing so, feel as though they can change the culture with patients and better involve patients in their own care? Thank you.
Thank you so much for your question, Paul. Yes, I do think that the new generation of clinicians and nephrologists can change culture. I mean, we have already seen a paradigm shift towards partnership between patients and clinicians, also researchers and regulators. And there's been a focus on shared decision-making and empowerment for self-management. And really, communication and education is really one of the cornerstones to this. And the words that we choose to use, which is a part of this, can have the power to help or to heal, or to even harm. And words also have the power to inspire or to destroy. So it's about really being conscious of our communication, the words that we use, and this can really help to change culture and even patient outcomes, the quality of care and patient outcomes in kidney disease.
Thank you very much, Dr. Tong, for presenting with us today. And to those who are watching, please go ahead on to see Jason. Dr. Tong's recent article is free access, and you'll be able to get better insights into her overall research and her background. Thank you very much, Dr. Tong.